I'm not the house of cards that falls down easily. I'm strong enough to handle what you throw at me.
Welcome to Mental Health News Radio. I'm your host, Kristin Sunanta Walker. Just what are we going to discuss? The intimacy that is mental health. Let's continue to make it as comfortable as discussing brain health or heart health. This show has been on the air for several years and we have amazing co-hosts. And then we created a network of podcasters on mentalhealthnewsradionetwork.com, a place where every possible facet of mental well-being can be talked about openly. My show, after several hundred interviews, the format is this: intimate, deep, funny, touching, sometimes uncomfortable, but always vulnerable conversations with interesting people. The goal is to have you, our listening family, many of you who have become my good friends, feel as though you are listening in on private conversations. Thank you for tuning in and becoming part of this amazing journey with me, and now with our network of podcasters. Just knowing this podcast might be helping any of you realize you are not alone on this journey called being a human being makes doing this podcast worth every second.
After all we promised, we'd be cordial.
Hey listeners, this is Kristin, and we're doing one of our episodes on our mental health business series. So I have my amazing co-host, Dave Ballenberger, on with me. Hi, Dave.
Hey, how you doing, Kristin?
I'm good. We have our guest today, her name is Shelley Samuels, and she is a principal at SRS Strategic Associates, LLC. She's got 30 years of experience as a leader in human services and healthcare organizations. Most recently, she was COO and Compliance Officer for a national organization, Juvo, Autism and Behavioral Health. The rest of the resume and bio goes on and on. I'm feeling a little insecure, but I'll just stop there and say, Shelley, thanks for coming on the show.
Oh, it's my pleasure. My pleasure.
So you and I have had the great opportunity to chat a bit first, and we connected immediately because we're both techies, but we're techies from that consultant level of techie, which means you have to have your eyes being able to see the forest through the trees as well as just the trees.
Yes, for sure. I call it being translational. Being as our role.
Yeah, absolutely. So tell Dave and I what we were just talking about ahead of time, because I think, no one wants to hear the real deal about what's going on, but they need to hear about the real deal of what's going on. I'd like to hear about it. So if you don't mind sharing what you just learned, that would be fantastic.
Sure. Yes. Obviously, we are in unprecedented times, and we know that healthcare, including mental health care, has to survive this, right? That's not something that you can find a solution to and just say it's over with, we don't need to do this anymore. I was just mentioning that I was on a webinar today where they were talking about the $30+ billion of loss that are expected to mental health providers this year because of the COVID virus. And nationally, the large number of providers that are reducing their services or having to close altogether. It's a scary time out there.
Yeah.
It really is.
And what's interesting is, we need mental health counseling more than ever, and people talking about mental health and mental illness is on the rise. It's
That's
now
right.
a part of mainstream conversation. So the fact that we're going to see this kind of loss, that we are seeing it, goes counter to the fact that we need it and people are accepting of needing it more than ever.
Right. I think one of the really stark pieces to this is I feel that folks that do direct care in all kinds of fields in medicine and mental health and with individuals with developmental disabilities are finally being recognized for the importance of their role at a time where we don't know what's going to be happening with their jobs. It's quite a dilemma to be facing.
Yeah, what was the type of impact that this, that you heard on this conference? Is it that mental health organizations would be closing? What
Yeah,
were they?
I mean, they're talking about actual closing their doors. I think that in the end of the service community that I come from, and I just wanted to add that prior to working with Juvo, I was the chief program officer for Easterseals, New Jersey, basically the largest provider in New Jersey. And we really dealt with individuals with the most significant mental health needs and developmental disabilities. And you know that those services are largely dependent on Medicaid payments.
Right.
And the margin between the cost and staying in business is very small.
Yeah.
Right. So if you're not on a scale like a significantly large Easterseals or, another organization of that size, it's always very, very hard to, become and remain sustainable, which is actually the mission of my firm, is to help organizations to do that. So, boy, you take away that minuscule little margin, and we're really going to see, I think, tremendous effects from this.
Yeah, and then you're operating in the red. You're robbing Peter to pay Paul all the time, which is extremely, extremely stressful.
Yes.
And listeners, what we're talking about is someone who needs to make, let's say, $10 an hour, but they can only be billed out at $12 an hour.
That's right. That's right.
That's the kind of margins we're talking about.
Yeah. And I think another significant piece of that now, at least in New Jersey, there's been a lot of efforts to pay direct care workers higher wages and then increase the Medicaid rate. But the margin's still really small. But you can imagine that, and one of the things I wanted to talk to you about is how very, very difficult that direct care work is, and how you must have a calling or some sort of dedication to it. And frankly, there are supermarkets or Trader Joe's or other places you could go and earn more.
And have health insurance.
That's right. And of course, now we know those folks working in the supermarkets, are under tremendous stress right now also. But, there is work that is much less physically, emotionally taxing than being a direct care worker, where you can earn more money.
Right.
So, this is some of the inequity in the system, right?
Right.
Yeah.
So do you think that the shakeup that's happening is because we were already teetering on a precipice and COVID just knocked us off of that? We can't keep robbing Peter to pay Paul. So something like this comes in and wipes it out, and then we have to rebuild because it wasn't working before. Do you think it's a lot of that?
Yeah, I usually what you hear, the general sort of number that goes around, is that 60 to 65% of organizations, when their states move to fee for service, 60 to 65% of the organizations fail.
Right.
So if you're already at that point,
right.
I like to call this, to some degree, this medicalization of the human services field. Medicine is set up to be much more profitable and successful in a fee-for-service or a third-party payer environment. After all, Medicaid, Medicare comes out of a medical model. But then when you translate that to human services, where really almost all of the staff and all of the fees that are being paid is at that lower level for a direct care person, that's where the rub is. Whereas in medicine, the majority of your practice is probably going to pay a physician or a nurse clinician or someone that, you're billing and paying at a higher rate.
Right.
Those positions don't really exist in the world of the, IDD provider or the provider who works with people with serious mental illness. It's very small percent. So the whole model is kind of set up around That's why I call it the medicalization, which kind of brings us to the electronic health record discussion, right?
Right.
Yeah.
Yeah. So Dave, definitely, I'm going to swing you in on this. I mean, you've seen for, oh my God, I don't want to say for you, but over a decade of trying to bill for a great system, but with agencies that are what Shelley's talking about, they can't afford it.
Well, I guess, I spent the first 15 years of my career a long time ago as a direct care worker. I lived with 15 delinquent boys 5.5 days a week. The good brothers gave me a day and a half a week off and paid me $7,000 a year. But that was a long time ago. I think part of the problem we're facing is that direct care and doing direct care has never paid well, and the people that go into it are really dedicated to what they do. But I guess kind of what I'm thinking about too is that government, Medicaid was moving more in the direction, particularly in behavioral health, of going to value-based payment versus fee-for-service. And a lot of the agencies that I think are going to have a very, very difficult time staying open are a fee-for-service agency. You have to have a certain volume of people come in the door in order to meet the budget. And I do think that, having spent a lot of time looking at value-based payment, and then I am with Next Step Solutions, and part of what we've done with our EHR is design it around value-based payment in terms of treatment plans no longer based completely on diagnosis, but also on teaching that person how to function with whatever issues or problems they're dealing with. But in that model, there's always a question about what happens to the people at the bottom who are the most chronic and the most severe.
That's right.
Because in value-based payment, you're going to find out you're going to have agencies, for lack of a better word, cherry picking and being very careful about who they accept. Now they're accepting, you come in the door, you need help. We sign you up, we get you registered, we find out what your Medicaid number is, or whoever the payer is, and then they start billing when they start providing service. In a value-based model, you're saying that you, at some point, are going to get this person better, and you're going to be able to prove it, and they're not going to come back for a certain period of time if they come back at all.
Right.
And that can, because the agencies are going to be expected to assume a lot more risk than they are right now. You're putting your whole place on the line based upon the fact that you say you can do this, then do it.
Right.
And we'll pay you.
Yeah.
And sometimes the model is talking about paying you at the front door. If you say, we're just working with an agency right now that has to submit their plan to the state. The state then tells them how much they'll pay to treat that person. And then, and they've already accepted them. And they've already signed the contract. So whatever the state decides, that's what they're going to have to deal with in relationship to payment.
Right.
And you're going to have to track that cost across a period of time and hope that for those people that you're not making as much for treating them, that you'll have others that you'll make more.
Right.
And I really think too, from listening nationally and some of the new rule changes that are coming out of Washington, that there is an effort to shrink behavioral health, and there is an effort to make it more of a medical model than a behavioral health model, for sure. I mean, that's what I see happening, and I think from talking to other directors and people that I know, they feel the same way. Do you see that?
Yes. Yeah.
Shelley?
Yeah. I actually, a number of things I wanted to comment on about what you had to say. Also come from direct care. for more years than you, many more, but I'll just leave it at that. On both the, the inpatient state psychiatric hospital side, as well as with folks with very serious physical disabilities and developmental disabilities. And, there's this terrible expression that fee for service, well, they try to say that this is what contracts are, heads and beds, right?
Right.
But really, that's fee for service, right? In its beginning point is the more people you serve, the more fees that you will be able to receive. New Jersey, we're just kind of midstream in getting into fee for service. So we haven't even begun to look at value-based payments in terms of the provider. And I think that, again, that's going to be survival of the fittest too, right? Like you're saying, I mean, it's going to be those large providers that actually have the time to sit down and say, let's collect outcomes data. Let's think about, what we're exceptional at doing. And let's try to, talk to the third party payers before it's imposed on us what we're going to be asked to do. So my understanding is, that has a lot to do with why those big healthcare networks evolve, right? Because they want to, one of the reasons is they want to have influence with the payers. Mm-hmm. And well, surely the providers that I, am focused on, that are doing residential programs and day hab programs and things like that, really, I mean, they're not going to have a lot of influence, and they are going to be told, this is what you're getting paid, and this is what we expect you to do. And if I could bring this around again to that direct care staff person, since we both share that background, I, throughout my leadership roles, and the last one with Easterseals, I had about 2,000 direct care staff that I was responsible for, and many more thousands of clients. And I used to make a big effort to go out and talk to all them in small groups and individually, because frankly, I've built my entire career, and my entire philosophy is that every decision you make has to be based on that direct care staff.
Right.
So, one of the things you hear when you go out there all the time is, I took this job because I really want to help people. It's my calling, or it's my passion to help people. And I didn't take it because I want to use a computer or sit at a desk or any of those things. And then we now, fee for service, whatever model, introduce things like, well, now you have to use an electronic health record. And you have to make sure that what you're working on with a client is related to what's stated in their goals, or that someone else stated was their goals. And, that individual may be responsible for 6-8 people all day.
Yeah.
So, you have to, it's hard to imagine how someone working in that environment, and how, organizations that are really their life's blood are those direct care staff, how they're going to really compete, in a value-based driven model. I'm not at all saying that the concept is bad. I'm just saying that what is really the reality, and is that a realistic expectation? Because frankly, if you don't have very satisfied, low burnout among your direct care staff, you basically have nothing. It doesn't really matter what the payment model is.
That's
right?
I ran 2 agencies, one for delinquent youth. And when I started out, we had 35 kids. And when I left, we had 210.
Right.
And I took the agency from a government agency to a private nonprofit, and was able to keep most of my direct care staff. And it's the only reason we were able to expand. And every year I would fight with the board about how much they're going to get paid and what their benefits are going to be.
Right.
Because, we had to take care of them. Direct care staff don't get taken care of anymore.
Oh, that is very true.
Most of the agencies that we work with, we had one agency in Iowa that lost 35 direct care staff in a week.
Yeah. Well,
because you had to cut their pay.
yeah. So, I'm agreeing with you that we don't take care of them, but I think we do know that in reality, it's not necessarily the fault of the organization, right?
No.
Because they have very, very slim resources, like we were saying, to give a raise or whatever it is. And I think that there needs to be more focus on things that, maybe don't have to do with money and have more to do with recognition and training and, things like that. It's providing other ways for folks to have some job satisfaction and feel good about what they're doing. It's rare that you'd find an organization that would say, I don't want to pay them more.
Oh, no.
Yeah.
Yeah, right.
And I wonder too, like how much of, let's say value-based care is going to hold water on the other side of COVID. There's so many things that are up in the air, that every industry just about is having to shift. And I like that we have this, focus on direct care workers, which are first responders too, and what their experience is. And we are doing flyovers with jets, and we are, doing all this appreciation. And yet, I hope that we see the appreciation hit the wallets. I hope we hit even more than that. I hope we see their working conditions, because something, and you guys can laugh, probably will, but I swear, I saw this at an agency that I was doing consulting for. And the reason why they could afford to do this was because they were privately funded by a very, very wealthy family.
How nice for them.
How nice for them. Exactly. That was a dream consulting gig for me, because I would be like, well, you need this, this, and this, and these computers. And they were like, here's a check. It was fantastic. And well, not to me, but, to buy the stuff that these people needed. But there was a lot of direct care. It was an autism organization, and they actually had their staff that did what you said, Shelley. We decided to become this because we want to help people. The physical activity of working with this patient that has autism and needs this kind of care, and we do not want to spend on this time on a computer. So you know what that organization had? They had scribes that walked around and typed the stuff that needed to be typed into the EHR, because you have to have it. It's not the evil EHR. It's, you have to have that information. It's called, that is part of medical care too. You have to have records. But they had the person that did the on the floor or whatever it is that they're doing with someone do their job, and the other person was there with them typing it all in.
Right.
Can you imagine if that's what we could or something, you know?
We're seeing that in medicine, right? You go into the doctor's office and someone's there typing. Where I think that becomes complex is that, especially with folks with disabilities, we're moving all to community-based services, right? So people you're not encouraged to have facilities anymore. And so you're out with folks, maybe 5-6 people all day. And I'll just say that one of the stories that really, really struck me, I was meeting with a small group of direct care people, and this was during, I think I've implemented 5 or 6 electronic health records over the years, but this was during one not that long ago. And I think 4 out of 5 of them said to me, you know what my biggest problem is? I can't get to entering stuff into the EHR until all the clients leave. Right. I can't do it when I'm out with them. And every day I'm picking my child up from daycare late and getting charged a late fee.
Right.
Yep.
So, this is the kind of stuff you have to really think about. This is the creative opportunity for leaders in the field and the re-engineering that you've got to come up with, because you can't bill without them doing it.
Right.
But you can't also expect them to give that much every day,
Yep.
And that's where the rubber hits the road, I think, with this whole thing, is how do you make it accessible to them to use these systems in a way that fits into what their daily routine is. Where I thought you were kind of going to go with the COVID thing is that, we're all hearing every day, wow, now we can do that with telehealth. Now we can do that on the phone.
Right.
So you know what? I'm hoping that one of the best outcomes of all this is that we realize that if we enable these direct care staff with a phone that has a smartphone, or maybe, a couple other technology advances, that maybe it won't interfere with their, what they need to do for themselves or their families or whatever.
Because
I'm
they'd be doing it on their phone at the,
we need to take more advantage of, and those solutions don't have to be super expensive either.
No,
right?
They don't.
Right.
And
we just haven't done it.
And we are. I mean, I'm seeing that, obviously. I mean, I see that with some of our podcasters even that are psychiatrists, and they're like, oh, let's, I will never use telehealth. Declarations, and guess what? Now they're using it because they're forced to, and they're like, this is the greatest thing since sliced cheese. I am so happy about it.
Exactly.
And I'm like, and I've seen more patients, but on the other side of that, I've heard some burnout from, I'm not used to sitting at a computer all day.
Right. Well, this is what I was saying, right? You cannot take someone who is dedicating their life to taking care of people and tell them that they now need to spend their time sitting in front of a computer.
Exactly.
That's not why they went into this work.
Right.
I mean, I don't think any of us would want that, right? To all of a sudden find out mid-career that you've now got to completely do another thing than what you've dedicated yourself to.
Yeah, and after 25 years of being on a computer and having carpal tunnel in both hands, I can tell you right now that I want almost no time on a computer.
Shelley, one of the things I see happening too is that, and this goes along with value-based care, and also goes along with primary care, that, when you hurt your foot, you go and see a doctor who specializes in your foot. What I see in your feet, and what I see happening in behavioral health is that one of the reasons, like, for example, we worked with 8 agencies in Iowa, and every one of them had 14 programs.
Right.
And I asked them, well, 14 programs, that seems like a lot. Well, that's the only way we get paid.
Yep.
We have to put everybody in as many of those programs as we can, demonstrate that we're doing something in each of those programs, and then we get our payment. And what I think is going to happen is that agencies are going to be told, out of those 14 things, which one do you do the best? And that's what we're going to pay you for.
Right.
And we're not going to pay you for the other 13.
Right.
Arizona has gone completely to value-based payment, and we work with a large agency there, and they have what they call value-added partners. So if someone comes into their clinic who has issues that clinic is not set up to treat, they call up one of their value-added partners, and then in the electronic record, they have to indicate that that's what they did, how come they did it, and what part of the treatment plan that is, not for them to get paid, but also for the other agency to get paid.
Right.
So in that sense, I think it is becoming much more of a primary care model.
Yeah, I think really what sort of screams at me from what you're talking about, and we haven't really hit on this, is integrated care, right? The behavioral health home, and we know that's not a home, it's just a home for your health care. integrated care is just, in my mind, is the answer to a lot of this, and so much the model, right? Because I actually started a behavioral health home in New Jersey, where my organization was the care management part. A VNA-run federally qualified health center was the medical part, and a behavioral health provider was the behavioral health entity. And they all came to our office, or we walked across the street to the medical provider. And this was only for people with serious mental illness. And so we were integrating their care. So I think there's maybe a little less loss of, when you're talking about an organization that's doing 14 services, probably less loss. But the other thing about the organization that's doing 14 services is that I think that largely comes out of a contract model.
Yes.
Where the state entity says, you know what, if the person is homeless and has a serious mental illness, then they go into this case management model. If the person's coming out of a state hospital and they need vocational training, then it's this kind of case management.
Yeah.
And so I think, but when you're a provider, wait a minute, I don't need to be doing all this separately and calling it 14 things. So I think some of the creativity that we're seeing, and it will happen, I think, more under value-based payment, is the connecting of all those things and all those, looking at the whole person, right? Instead of where they lived and where they came from. One of the things I find so fascinating, and I know this is not unique to New Jersey, is that you could be a young, let's say a teenager, and you have some kind of psychotic break or something, and you end up in a state psychiatric hospital, right? But lo and behold, you also have a developmental disability. But you know what happens? You're now in the track of having a psychiatric illness, and you now get all your services through the part of the government, the entity that covers mental health. The exact same person could first get diagnosed with a developmental disability, end up, in that system, and then later on they have a psychotic episode. They're going to stay in the developmental disability side of things, right? Mm-hmm. So we talk about integration. We haven't even integrated to that degree where we're looking at the whole person and looking across different service lines and funding categories to how to best serve them. Are you seeing that as well? Because I see a lot of that.
Yeah, I see that going on. I think what also happens is, particularly what we're seeing a lot of now too, is we're being expected to provide interoperability in our software.
Oh, yeah. Yes.
Where we can talk to 3 different other systems all at the same time.
Yep.
And that's a fine and dandy idea. But making that happen is not always the easiest thing. Let me close my door.
Okay.
Lawnmower and a dog.
Yeah.
Hey, we're still working from home, all of us, so it's okay. And I want to make sure listeners know the date today is May 7th of 2020. As I've said, we're doing dates just so people know where we're at in terms of the virus,
Well, I sent my dog to a babysitter.
I keep having Dr. Mark Feldman, who's a leader on Munchausen and Munchausen by proxy, and he keeps having to cancel because of the dog sitter thing. And I said, Mark, it's okay. I mean, I want you to come on, like, if your dog makes some noise. He's like, no, you don't understand the level.
I have a dog that I have very proudly spoiled. He's only a year and a half, and whatever. So, but I'm just to get back to what you were saying about now we're talking interoperability, right? And you're all probably know way more than I do about EHR, though I've actually ran an electronic health records business for Easterseals. Look at when you look back at the start of meaningful use, and it was real nice back then when the federal government was giving hospitals, whoever, funds, right? Well, you don't think that ever hit the human services and the mental health field. So we all had to scratch our way through to doing this ourselves. Yep. And one of the things that's so striking to me that was missing from that early legislation was the requirement that these things be interoperable.
Yeah.
Nobody thought about it, right? So
Nobody
now,
thought about it then. Right.
No. So now you go out and you buy this fancy thing, and I don't know about you, but I know many large organizations, listen, even hospitals, right? And especially with all the mergers and acquisitions that are happening, they can't even speak to each other inside their own organizations.
Correct.
Different departments. And, the systems are not set up with an open, an API, right?
Yep.
And so then you got to fiddle around with that. And of course, we're really going to be a significant issue if we really, really, truly do integrated care. When those systems, and you're talking about value-based payments, if we can't collect data across these entities, that's serious.
Yeah, absolutely.
Issue.
And so, that's going to become a bigger and bigger problem. Yep. But at the same time, the people that have to provide the service, things have to get easier for them too. It's huge.
Yeah.
And, we go to work in states where they tell us that they're going to go to value-based payment, but they don't change any of their rules. They don't change any of their funding rules.
Yeah.
They don't change anything. And they say, well, you on value-based payment yet?
Yeah.
Well, no, because you say that we have to submit these 1,300 forms.
Yes.
And those kinds of things. So,
right.
Yeah, there's a lot of things. I think, with what we're going through right now with the pandemic, having sat and having worked in behavioral health for 45 years, that I kind of see it as an opportunity now for government to really begin even more process of shrinking behavioral health and having primary care become responsible for mental health as well as medical health.
Which is absolutely frightening.
Yeah, it is, isn't it? I mean, I was truly amazed, and I guess I should have known this. I don't know, I assume this is nationally, that physicians can prescribe medication, right? Right. And they don't have to have training as a psychiatrist or anything, right? To do that.
What they do is they give somebody psych meds, and then when they come back and say they're not better, they give them more psych meds.
Yeah.
And then when they've maxed out on that particular medication or medications, they change them.
Right.
And start over again because what I'm seeing happening, I go back to Arizona because the agency that we work with has now signed a half a dozen contracts to provide behavioral health services in the primary care office.
Yes. Mm-hmm.
And so when the doctor sees a problem, he calls down the hall, and somebody comes down, but yet the primary care doctor is not going to read a social history. He's not going to look at a treatment plan, or she, and because they got 15 minutes.
Right.
And they got to move on.
Yes, right. Mm-hmm.
In terms of what's going on out there, I just see a real effort. And as far as residential care goes, that's going to be a thing of the past.
Well, that may very well be true. The one piece of it that does make me sort of think that may not happen, and maybe it will only not happen for those folks that are severe, really, really seriously ill. And that is because, the thing they don't want to do, I don't know who they is, but it's the big they out there. They don't want these folks in the hospitals.
No.
Right? And they don't want them in long-term care facilities.
No.
So residential is actually, besides it being in many cases a better solution, it's a more cost-effective solution. So I don't know that residential programs will really go away. Now, again, it could be that there's much more dependence on people who can even marginally make it on their own, living in some kind of supported model as opposed to like a group home model. I mean, we do know that, what states are building new group homes. Nobody's really doing that. But I don't know that the residential model will go away, even just plainly from a financial perspective. It's still cheaper than putting the person in a hospital, right?
Yeah.
And what I've seen happening is that where residential programs might have had these mandates that they have 24/7 coverage, in a lot of cases that coverage is being reduced. And the way you do the coverage is reduced. So some of that is going to be this telemedicine is going to be responsible. Yeah. And that in many cases, that's okay, because folks can function much more independently often than we think they can. But it's just not always the safest thing. But so I don't know that I see residential going away as much as, there's such a movement to get people out of the hospitals and institutions and into the community.
Yeah, one of the things that bothers me is it's probably because I spent most of my career in residential care. I spent 30 years with delinquent boys. Mm-hmm. And my young lads needed to spend 6 to 9 months with people telling them what's right and what's wrong over a period of time, and being held accountable for the behavior, because now there's not that many adolescent beds anymore.
Right.
And so kids go home, they do the same thing. They go home, they go to detention for a few days, go home, and this wonderful treatment plan is written. And at the end of the day, they end up going to prison because we haven't gotten rid of the prisons. Right.
Yeah.
So we kind of nurse them through their adolescent years, doing things that everybody knows are not going to work. And then they end up in jail, and then they end up in prison. Because we are not getting rid of our prisons.
Well, we're letting people out right now.
Yeah, I know.
Because of COVID.
Right, right. I know, and we don't know what this is all going to look like. What's astounding to me, and hearing about, the open minds discussion is, it's not really astounding, because what is surprising? Everything is surprising and nothing is surprising right now. But
that's exact great way to put it.
But it's like, okay, so what the heck is going to happen to healthcare overall, and specifically, mental health care, because we need it now more than ever, and yet agencies are being, have to close down. So we're in a world of hurt that I hope we change things that have been broken forever, and that this called it to light in a way that only something like this could do. Right. And so that means that, okay, let's now actually try to, we know it's like this, Shelley, it's like this. And Dave, you and I have had this conversation a million times, and Shelley, you and I just had it. It's like, what we saw with EHRs, like agencies, when I started in behavioral health and technology, meaningful use was just coming out. Agencies were on paper, and those systems that they were using on paper were broken. Now, I'm not saying going to an electronic health record made it better, but some things changed, and some things changed for the better. And there was a drive to do that. And that was without a pandemic. So, and agencies now, I felt like I did a good job as a consultant, and I got rid of myself, because agencies did not need consultants like me to come in anymore and say, this is how you select an EHR, because my God, they have 4, 5, and 6 of systems now. They know what they're doing. They don't need me to tell them. I hope that maybe something like that is what we'll see happen here with, we know what's broken and what didn't work. And some people did okay even with that and were successful and good in a good way. I hope that some of that is what we craft out of this pandemic.
Yeah, one of the things that I'm hearing out there, which probably scares me the most, and I hope is not true, is that the number of people who are homeless now is going to just become, is going to grow substantially because of service providers not being available anymore. And I hope that is not true. And I'll just tell you, one sort of positive story about all this, which I think goes to what you're saying, is I have a client that is a federally qualified health center. And they have always been extremely advanced when it comes to technology. Their CIO, who's also their COO, started out as a nurse. And what they are doing during this pandemic, first of all, they started reading news about it very early on and preparing for it. Right. And they're in a very, very high density, high risk urban environment. Matter of fact, probably one of the most affected environments right now with COVID in New Jersey. But they immediately were able to move into using more telehealth solutions because they had been doing it already, So hopefully more organizations will take what they're learning now and hold on to it. One of the things they're actually doing is very fascinating, is they took over an empty wing of a hospital, and they are accepting homeless COVID positive patients there. And I think they're probably one of the only ones in the state that are getting transferred from all over the place, different hospitals and places. And the physicians are able to remote in. They have these robots that have iPads attached to them that are going to patient rooms. The nursing staff is on site, but using all technology to monitor the patients. Of course, they're going into the rooms and stuff.
And you're talking about literal robots.
Literally a robot.
Not a human being that's a geek that's like, I am a robot. Okay, a real robot. Got it.
And they're able to remotely check blood pressure and heart rate and all this stuff. You know what, though? They were doing some of this already.
Yeah.
So if they can do that, maybe other organizations, will take the solutions they're using now and expand it, right? Because that's a tough population. And now what's happening is some of these homeless people don't want to leave. They don't want to go back out.
I wouldn't want to either. And, Oh, wow. Yeah. Well, I don't know that we've solved anything today, but we try. We need to have the conversations, conversations, because putting your head in the sand about it isn't going to help. This is happening. This has happened. And, it affects like I said, it affects every company, organization out there, and it's affecting mental health big time.
Big time. Absolutely.
The PTSD and the trauma and all that everyone across the entire planet is feeling, along with what our first responders and direct care workers are going through and are going to go through for years to come.
That's right.
Lends itself to us taking these conversations, having them, taking them seriously, and keeping our eye on what's going on. So Shelley, I am so glad that you do what you do and that you stayed in the consultant world. I took my exit and got into podcasting because I was like, I'm out. I can't do it anymore. But I'm so glad that you're here.
Thank you. I first of all, I have to tell you, I love it. I've only been in it for less than a year now. That's how recently I was in the actual organizational side of all this. I feel like I have an opportunity to assist in so many more ways. So it's a great adventure for me, for sure.
Well, tell our listeners where the heck they can find you and your organization.
Sure. So the name of the organization is SRS Strategic Associates, and if you look us up on the web, you'll see us there, and that's also our web address. And you can see all the different services we provide. We're doing a bunch of free webinars right now to give back to the provider community.
Yeah.
And we're always happy to talk to folks, have an initial conversation without charging you anything, because I have to keep reminding folks in my firm that we're not nonprofits anymore. But
right. Oh, believe me, I know that one too.
But it's easy to find us, and this was just a fantastic opportunity. I've enjoyed every minute of this, so I really appreciate you.
Absolutely.
Giving me this opportunity.
Absolutely. And listeners, thank you for tuning in to our Mental Health Business Show with myself and Dave Ballenberger on Mental Health News Radio.
Hi, listeners. I'll make it quick. These are some really cool places that give discounts and other cool things for listeners of Mental Health News Radio Network. If you want to get amazing help with healing from narcissistic abuse, go to healfromanarcissist.com. If you want CBD products that are the best of the best, I use them myself, go to proze.com and use the code mentalhealth20, mentalhealth20. If you want to get daily perk ups that help retrain your brain to think more positively, go to perkupdaily.com. And also, just because this one's fun, snarkycandles.com. I guarantee you'll love them. Snarky with a Y, SNARKY, candles.com. And don't forget, if you want to hear all the shows on the network about first responders, you can go to firstrespondermentalhealthnetwork.com, and all of our shows that focus on narcissistic abuse, narcissistabusehealingnetwork.com. Thanks for listening, and back to the show.
Sometimes I'm passive aggressive, but never without good intentions. I heat up and act on my emotions.
Thanks so much for listening to Mental Health News Radio. Our podcast can be found on iTunes, Stitcher, and hundreds of other podcast apps, or you can visit our website at mentalhealthnewsradio.com. If you have a question or would like to be a guest, become a podcaster on our network, or join the amazing organizations that help keep us on the air, please email us at info@mhnrnetwork.com. Get ready for that special goodbye from our resident therapy dog, Miles, and a special thanks to Emily Sohn for letting us use her incredible song, Cordial, for our podcast music. Listen to the full song on SoundCloud at emily.sonne.
Don't be surprised when I don't hate on you. After all, we promised we'd be cordial.